right, these were wonderful presentations. Thank you for all our wonderful surgeons. And our next session will be the most exciting one, which is the discussion with the surgeons. So I am going to ask some of the questions from that came on Zoom, and then we'll see what our wonderful surgeons think about it. Okay. So one of the questions that came from Dr. Abdulrahman Hussein for Dr. Morell is about the height of the VSD patch in these patients when you're doing the Nakaido. Like, would you make it long or short? And also he noticed in the video that you may close the VSD before you do the anastomosis. So does the timing matter between like closing the VSD and doing the aortic anastomosis?
Sure. So I usually don't close the VSD until I have that aorta set. So I will do the translocation, suture it as much as I can from the edge on the left side of the pulmonary, what used to be the pulmonary valve annulus, bring it across to the right side, and then close the VSD. And that sets the height of the VSD because the aorta is already set. So by doing that, you avoid, if I were to close the VSD before I translocate the aorta, then it kind of doesn't fit my eye as a surgeon. I would set the aorta in place, and then I would create the VSD patch and get it as high. You know, you don't want to make it too short and pull the aorta inferiorly because that aortic annulus, it could be distorted, so you have to be careful when you do this. But I think the easiest way to do this is just translocate the aorta, suture in place, and then just see where the VSD wants to sit, the height of it.
That's great. Thank you, Dr. Morell. A question to Dr. Sandoval was about if you have a small VSD or a remote VSD, would you still be able to do the Rastelli procedure? Or would you enlarge that VSD during the procedure?
Thank you very much for the question. I think it's very important because we see the series of the latest result from Al-Hadith, from other centers. They say that if you remove not only the contraception, but if you are large the VSD, you will avoid use of the LVOT absorption in the future. And I think it's the bad thing about Rastelli, because all these surgeons have a very old experience and a long-term survival. The same with the right ventricular outflow. But I think it's very important. We try to do, but the problem is that we don't see many patients a year. To do 1 or 2 operations a year, it's not going to make a big change. At least we have some multi-center studies. But I think it's very important to enlarge the VSD. Even if they are not big enough, some surgeons recommend to enlarge the VSD and be aware of the baby blood. Because it's an issue of the implantation of pacemaker.
So would the Nakaido be a better operation here, Dr. Morell?
Yeah, I mean, I think when you have a remote or somewhat restrictive VSD, I mean, clearly you could just enlarge it and do a Rastelli. It's an option. We would usually consider a Nakaido for that type of patient. But I think it's important, and I'm interested to see what Mark does routinely, but when I do a Rastelli, I always enlarge the VSD. Always. It's just part of the procedure. You want to make it that communication as large as possible. And I don't know, do you routinely do that, Mark?
Yes, when I do a Rastelli, I try to make the VSD as big as possible. And coming back to the question, I think the Nikaido operation is the best option if you have a very small VSD, or when the VSD is distant from the great vessels. Then, of course, a Rastelli is usually not possible, and there are some limits to how far you can go with enlarging a VSD. And then in these cases, usually a Nikaido operation is much easier and probably better also.
Yeah. And as a follow-up question for Dr. Hazekamp, There was a question about trying to do the double root procedure for double outlet right ventricle with a remote VST. So would you know, like, I know it's not transposition, but would you be able to do that procedure in a double outlet with remote VST?
It's a difficult question for me because I have never done a double root translocation. So I have only done the typical Nikaido operation. So probably it could be done, but to be honest, I have never done that, so it's not a good question for me.
So Mark, let me, you know, I think, as you well describe, I think this issue about the double root translocation as opposed to a Nikaido, you know, in my eyes, the aortic root translocation manages historically, initially, when it was all about the left ventricular outflow tract, and you move the aorta on top of the left ventricle to create a direct connection. And the right side, the reconstruction of the right side was somewhat of a secondary problem. With the double root, they're trying to address both sides as opposed to just the left side. Okay, but just like you mentioned, I feel that if the pulmonary valve is good enough to last a lifetime, in my eyes, that's a patient that maybe should have had a switch with a left ventricular outflow tract resection. In the patients that I've done double roots, and I do it differently, I harvest the aorta and I harvest the pulmonary root separately, like Dr. Hu does. That's the way and I done the Yamagashi technique also, but I find that at least for me, it's easier just to harvest both separately. But those pulmonary valves, they were no good for a doubles, for a switch operation. They were good once I put them in the back table and slice and dice them and dilated them, and then put it back in the right side. Then they become useful as a conduit. I'm not sure they're gonna be competent, or they really weren't terribly competent on the table, but they were a conduit that can grow. When you look at those series, anywhere between 30 and 45% of patients on a very short follow-up have wide open PI. You know, so I'm not sure that route worked in any way, shape, or form. You know, so I think it's a complicated equation. Here's the right side, there's the left side. The double root supposedly addresses both sides, which I'm not sure is a true statement. I always believe avoiding conduits is a good idea, and the double root, but if you transect the main pulmonary artery just at the level of the pulmonary valve, if the pulmonary valve is no good, you can do a direct RV to PA connection, and to a point you're addressing both sides. A lot of those patients are going to come back anyway for a pulmonary valve.
Yep. And as a follow-up question for that, when they come back for a pulmonary valve replacement, let's say you do it like a direct connection of the branch PAs to the RV, would you put like a valve or would you put a conduit at that time?
So I'll be honest with you, I haven't seen, I've had to do that only a couple times in my experience. So I have, you know, the first, most of the Nikaidos are sitting out there with direct RV to PA connections, and they haven't come back as they want until, I'm sure they're going to be in their late teens or 20s. I have my first patient here in Pittsburgh that I did here, he's 21 years old, and he's walking out there with no pulmonary valve, still with the direct RV to PA connection, without a dilated right ventricle, and really with no exercise restrictions. So, but in the ones, I remember one patient specifically, I ended up putting an RV to PA connection. I put a conduit as opposed to a valve. That patient came specifically had AI, so it didn't come really to me because he had pulmonary insufficiency, and that was the indication. Unfortunately, that patient had aortic insufficiency. I had to replace the aortic valve, and at the same time, I opted to put a competent valve in the pulmonary position. So a little more complicated.
Excellent. There's a nice question that came from the audience about the timing of the procedure, and I would be curious to know like the thoughts of all the surgeons. Let's say we have a baby that was born today with a transposition of the great arteries with VSD and pulmonary stenosis. What would be your preferred timing or weight to do the procedure? And would it matter if you're considering a Rastelli versus a Nakaido procedure? Maybe we can start with you, Victor.
So I've done Nakaidos on newborns. Honestly, I feel that if I had a newborn that is blue with this anatomy, I would shunt them and then have them come back about 6 months of age and do a Nakaido. If I have a 2-month-old kid that was born, went home, now comes back 2 months old and he's blue, I would probably just go ahead and do whatever I need to do and avoid just during the neonatal time. I would consider doing a palliative procedure. After that, I feel that kids could, easily undergo either, honestly, for that matter, a Rastelli or a Nakaido or any other operation we decide to do. Ideal time for me is about 6 months, honestly.
Fantastic. Dr. Hazekamp?
Yes, for me it's a little bit different because first of all, I always used a bovine vein conduit. So I try to postpone the surgery until the child is around 8 kilos, and that is between 8 months and 12 months, something like that. And if necessary, then they get a shunt to wait a little bit longer, because I want to put in a container conduit of at least 16 millimeters so that they last a longer time.
That's great. Dr. Sandoval?
Yes, I'm agreeing with Mark. We normally wait. We put a shunt. Our series, 80% of our patients had a shunt. Follow up these patients is difficult in developing countries. So we rather put a shunt and wait until we are able to fix it and put a large conduit. And when you listen more about valve and tetralogy of Fallot, you are wondering if you shouldn't place a valve in the conduit, just the conduit, and wait, and maybe that conduit will last longer than the valved conduit. And I'm not sure about that, but I think it could be a strategy for the small patients.
Great answer. Dr. Castro, what's your opinion on this?
Well, usually it's put a PDA stent as a newborn or a BT chon, let it grow, and I'm considered like the best age to come back is 6 months. If you ask me, I mean, can be early, can be late. I think the longer you wait, there's more, the RV is gonna be more thicker sometimes in these patients. I mean, I only have a few experience. I went to León, Guanajuato a few years ago, and we did my first Nakaido there. The kid was almost like, 15 months. It was so blue. Let me tell you, I cooled down to 18 degrees. I know Victor will say that's crazy, but, I did not have a choice. So that's why, in my opinion, but usually I understand Dr. Sandoval, all these kids, they're gonna come back later for him.
Excellent, excellent. Another question that came from Dr. Antonio Benita, he's asking about adult patients. Like, let's say there was an adult patient that was not operated on with this anatomy, with borderline LV, he kind of like typed the specifics, left ventricular outflow tract obstruction, subvalvar, and a large VSD, and also some anomalous attachments of the mitral valve. What would be the surgeon's approach on this?
I mean, thank God, a lot of those complicated patients, at least in the US, in my experience, I remember when I was starting my career in the late 1990s, early 2000s, that there were quite a few adults with complicated anatomy that were never managed. I mean, I will tell you, I've done certainly Rastelli, 40-some-year-old, we did a double switch Rastelli sending on, who was, I don't remember how she was palliated, but she was very blue. And so, you have surgical options if as long as you can partition the heart without creating major issues for the patient, you know, a Rastelli, a Nakaido, you know, clearly doing Hazekamp maneuvers in adults is not, things don't move as well when you're an adult. So it changes your approach a little. I think on somebody like this complicated, maybe blue, I would try to do the simplest procedure I can to get him through, you know, to turn him into a BIV, but anyway, I'm not sure what the other ones were.
Dr. Hazekamp, any comments?
Yes, in the patient of the question of that we're talking about, adult patients with borderline LV, LVOT obstruction, subvalvular large VSD, and anomalous attachment of the mitral valve. It sounds like it will be very difficult to septate this heart. So probably, yeah, I don't know. Depends on the symptomatology. If the patient is blue, then I would just go for a shunt because Fontan in an adult patient is also not always the best option. So it seems a very difficult patient in this case, and probably coming a little bit late.
Excellent, thank you. Dr. Sandoval, any comments for this patient?
No very smart comment from me, but if I were Antonio Benito in Mexico, maybe I'll do, John, thinking maybe in a univentricular heart repair because the PA must be low and maybe a univentricular repair could be an option, but it's a difficult situation that we found in developing countries, adult patient without any previous repair. And I think that the 3D model will help you to decide what to do the best for these patients, but I don't have any specific comment. Thank you.
Excellent, thank you. Another question came from the audience also about the REV procedure, and it seems like it's falling out of favor in the US at least.
Mark, what do you think, Mark?
Yes, so I think the REF operation is a typically French operation. It was invented by Yves Lecomte from Paris. The name is an abbreviation for Réparation à l'étage ventriculaire. And even in Europe, I know that in the North Americas, there's not much experience with the REF operation, but even in Europe, the REF operation is almost exclusively done in France. And they still do this, I know, and I think it's not a really bad operation because you have to resect a lot of infundibulary septum so that you flatten out your VSD patch and get a more or less straight connection between the left ventricle and the aorta. But it never, never got viral in the rest of the world for some reason.
You know, it's funny when I think about the REV, the only thing I get from that operation was what really has proven that if you do a direct RV to PA connection, you have less reoperations. And their data proves that. So for me, a REV, it's a modification of the Rastelli, but the really cool concept of it was that they did a Hazekamp and they brought the PAs directly to the right ventricle, and they decrease, if you look at, you know, Dominique's data to Yves' data, stuff like that, they've proven that the reoperation rate for the right side is significantly lower than the Rastelli. Even though it sits in a non-anatomical positions, it still could be compressed by the sternum because it's different than an Nakaido. You're not moving things down. You put in the PA on that RV to PA connection anteriorly, but because you avoid a conduit, you have less reoperations. And that's really what I got out of the data of the REV.
Excellent. Another question for Dr. Morell and Dr. Hazekamp was, how do you reconstruct the pulmonary valve? And how do you reduce the RVOT opening size when you're doing the Nakaido?
Yeah, so the RV opening side is a good, I get that question a lot. And usually when you do a Nakaido, you end up with this awkwardly shaped RV outflow, especially in the corners where the aorta is anastomosed, so that those corners down there posteriorly I usually try to put platelets and reduce the size. I think at times the mouth of that RV outflow is quite big and awkwardly shaped, and you're trying to recreate it into a more rounded, more normally shaped RV. So then you either can put a conduit or you do a direct RV to PA connection. But usually I put platelet sutures and kind of plicate those corners until I get a shape that it suits my eye for the surgery. Mark, do you do anything different?
Exactly the same, and yeah, I've encountered exactly the same. If you don't reduce or plicate the two corners, then there are two problems. It looks awful, and it's really very big. So you have to reduce it. And the other thing is, as I use a conduit, I use a container, and I wrap it around the organ, either on the left side or on the right side. That depends a little bit on how it falls best. Then you have to do that as well to avoid compression of one of the coronaries by the conduit. So yeah, so I do exactly the same.
Fantastic discussion. One last question also came from the audience. When do you choose to do the Hazekamp maneuver or not? And also, when you're doing a VSD enlargement, what direction do you enlarge the VSD and how much do you cut to avoid AV block in patients?
Is that for Rostelli, I would imagine?
I think they meant Rostelli here.
Okay. I mean, obviously for Rostelli's, I never do a Hazekamp. For an Akaido, I would say I've done a few Nakaidos without, because anatomically it fit kind of better. Especially, we didn't talk about it today, but with LTGA, I usually don't do a Hazekamp when I do a Nakaido for LTGA. But with that said, you know, when you do a Nakaido, you're transecting the outlet septum into the VSD, so it's anteriorly, obviously. With a Rostelli, it's anterior and superiorly to avoid the conduction system. And with that, and from Al-Sufi's paper, you know, you can still get heart block. I mean, so you have to be a little careful, but you know, the textbook answer is you go superiorly and anteriorly.
Superior and anterior. Fantastic. This was a great discussion. Thank you very much. For the sake of time, I'm going to go ahead and conclude this session. I want to thank all our surgeons, and final remarks by Dr. Olivieri and Dr. Morell.
Thank you so much, and a special thanks to Drs. Sandoval and Hazekamp for joining us and really bringing their unique perspectives. We are so appreciative to them and to all of our speakers, as well as to our support team here in Pittsburgh for helping with the organization and the technical aspects of this symposium. We are just, very grateful.
I hope this was useful. If you have any other questions that we haven't addressed, please, the chat will be open for a little longer, and you can just put those questions into the chat, and we'll try to get back to you guys. Again, I want to thank Mark and Nestor for participating in this. Thanks for being here with us. And anyway, enjoy the rest of your evening, day, morning, or whatever that might be, okay? Take care.
Thank you.